Again, thank you so much for joining us. Before we begin our speaker program, there are a few housekeeping items we need to mention. CME guidelines require that disclosures are made at all accredited activities. Dr. Paul Benson reports he receives payments for his role as speaker for Gilead, ViiV, and Munson. He also reports he receives grant funds for his role as researcher for Gilead and ViiV. All other faculty and planners for the 2021 Northern Michigan HIV Summit report that they have nothing to disclose in the context of this activity. All registrants will receive an email with links to claim CME/CE credit during the event. Certificates will be available instantly upon completion of the required evaluations. Our first presenter today is Dr. Paul Benson. Dr. Benson has had a family practice in Berkeley, Michigan since 1980. HIV medicine has become one of his life's passions. His work with HIV patients has given him a greater appreciation of life and made him a more compassionate physician and human being. Today, he'll discuss fine-tuning cultural competency in HIV. Please welcome Dr. Paul Benson.
Thank you very much. Are you able to see my slide?
Not yet.
How about now?
Not yet. There we go.
Okay, perfect. Sorry about that. Technology has never been a great forte of mine. Everybody in Traverse City, thank you very, very much for having me. You are in beautiful, beautiful country there. I enjoy taking my trips up to Traverse City as often as I can go there. I love the whitefish, and perhaps next year the situation will be available that I can actually come speak to you in person. So I'm going to talk to you a little bit today about cultural competency and the lessons that I've learned after being in practice for 40 years, providing primary care to our LGBTQ community. I would like you to humor me for a minute, and I have some polling questions that I would like to be able to interact with you to bring us closer. So if everybody can pull out your cell phones and text message me, the text message should be my name, Paul Benson, Paul, B as in boy, ENSON, 401. That will be the text message. And the telephone number that you will put in to text me will be 22333. Please do this because it's going to allow us to chat with each other, and I think it'll be more beneficial for everybody involved. So I'll give you a minute, 22333, and the text message will be my name with the numbers 401. I'm going to go to the next slide to test this and see how many people are doing it. Please do it. I've been on the other side a lot of times, and I know sometimes it's easy not to do that. So which of the below describes you best? A, primary care provider, MD, DO, PANP. B, a social worker or case care manager. C, a student. D, clergy. E, public safety. F, health department, and G, other. So when you start replying, we should see some answers. There we go. So we know it is working. Beautiful. Music to my ears. Keep going. Keep going. You know, I've learned while you're answering the question, I've learned that it really takes a community to manage an HIV patient, and perhaps patients with other chronic diseases as well. Any doctor cannot do it themselves. We need a team of people. People come in front of me, I see them for a small snapshot in their lives. I rely very heavily on my team members, from the person answering my phone to the medical assistant, to the pharmacist, to the social worker that we have in the office. They all relate to the patients. Sometimes they get very valuable information that I don't get from a patient, and they share it with me. So, my kudos, my hats off to everybody that's part of the team, because really it's the team members are more important in the healthcare of the patient than the doctor themselves. So again, thank you all for what you do. It's an extremely important part. You should go home very, very proud. So we've got a few from the health department, we got a few students, some social workers, and some primary caregivers. This is a great eclectic audience, and I'm looking forward to having a productive discussion with you. My goal, if I can get you to just do one thing differently, one thing better to affect one of our patients' lives in a better way, then I'm very, very happy and successful that we can do that. If you would be so kind to answer this next question, you identify yourself as A, gay, lesbian, transgender, or non-binary person, 2, an ally of the LGBTQ community, C, a cisgender heterosexual, or D, prefer not to say. And the polling keeps coming in. We'll give you another minute. So I know by virtue of this conference that I'm really singing to the choir. And that's okay, because you know what? Choirs don't get to be good unless they practice and rehearse all the time. So there's nothing wrong with that. A person identifying themselves as an LGBTQ individual to their healthcare provider is perhaps one of the most important things they can do to maximize their care. You can go from A, strongly agree, to E, strongly disagree. Go ahead, you can answer that question now. Hopefully it's still working. I'm hoping that the polling system is still working. Again, you want to text my name, Paul Benson, with the numbers 401, and the telephone number is 22333. You don't think it's working? You're trying it as well? Okay, we're going to go to the next slide and we'll see what happens. We're almost done with polling questions anyway, but at least it's giving you food for thought or something to think about. Due to fear of discrimination, past negative experiences with healthcare providers, and false beliefs, many LGBTQ individuals do not seek out needed medical care. Thank goodness I'm seeing numbers come in. And, I strongly agree with this statement. I've been practicing since 1980. I've seen a lot of changes. Many people in any minority, doesn't have to be the LGBTQ community, have a distrust of the medical system, perhaps have been treated poorly by it, and are scared to go to the doctor. And they probably live by those words, maybe it will go away on their own. And as a healthcare system, we need to do better. And truthfully, a LGBTQ person should not need to seek out an LGBTQ clinic or physician. Everybody really should be treated equal, and people should be trained, if you're a healthcare provider or a social worker, to be able to identify with this community. It's extremely important. So change is necessary. This world is changing at a rapid pace in so many different ways. And medicine changes as well. And sexual activity and sexual behaviors change from the roaring 1920s, where people were more promiscuous, to the Depression, where people were less promiscuous, to after World War II, when our soldiers came back with lots of STIs. We're in a constantly changing environment. This slide was from the 1970s, from a magazine called Life magazine, which was a very popular magazine for those of you that remember it. And this was one of the advertisement pages in there. More doctors smoke Camel cigarettes than any other cigarette. We look at that as like, how could that possibly have been? We're only talking, about 40 years ago. And this ad goes on to talk about the pleasure zone, the T zone, and the doctor that wakes up in the middle of the night, takes a couple hits of his cigarette, answering a phone call, and then gets up early in the morning to go back and see patients again. We look at that now and we think it's ludicrous, but some of our behaviors and some of the things that we're doing now are just as ludicrous. And when we look at them 10, 20, or 30 years from now, we may find the exact same thing. So we have to be open to change, especially when it comes to human sexuality, because it's different than it was many years ago, especially with the advent of social media. It's changed quite a bit. So this is one of our last polling questions. Of changes in sexual attitudes and practices over the past century include A, the American Psychiatric Association removing homosexuality from a list of mental health disorders in 1973. I look at myself, I was 20 years old in 1973. Was I mentally ill before 1973, being a gay individual? B, the first national march for lesbian and gay rights occurred in 1979, associated with the Stonewall Rebellion. C, outbreaks of syphilis and gonorrhea from World War II brought interest in sex education by the public and the government. D, not that long ago, Supreme Court allowed for same-sex marriages in 2015. And then E, which looks like you guys are spot on, all the above are true. It's hard to believe in 2021 that same-sex marriage was not possible. And just 6 years later, it's a commonality. It's astounding. And the point is, everybody needs to be open to change. And when you talk to your patients and you counsel your patients, and you give them advice, your thought process can't be in the 1990s or in the year 2000. It's got to be with 2021. And believe it or not, we are all resistant to change. None of us like to change. And I'll tell you something you could try and do tonight if you want to see about how we're resistant to change. When you go home tonight, if you have a partner that you sleep in the same bed with, try changing sides. Take the other person's side of the bed, make them switch. See what kind of hesitancy there will be towards change. So we're going to flip gears a little bit right now. We're going to talk about making your clinical practices better in addressing the medical needs of the LGBTQ community. And again, you could substitute in any other minority into this equation instead of LGBTQ, because it all follows about the same. I strongly believe that a doctor's office is like a safe harbor in a sea. And when there's a storm, boats can come into a safe harbor and stay safe out of the storm. And it should be the same way a doctor's office is. We should be safe harbor for anybody that has any lifestyle, that when they come into that office, they can feel safe and secure. That, my friends, is cultural competency. In my office, it starts right when they open the door. This is our non-discrimination policy. Now, most offices hide this on an 8.5 by 11 sheet of paper and tack it up on a bulletin board or somewhere, clear out of view. In my office, this is framed nicely right at the front door that you cannot miss seeing it when you walk in. And I want to read it because I think it's important. This is a safer place. We are committed to provide quality health care and serve our patients without regard to race, nationality, ethnicity, gender, religion, even political preferences, or sexual orientation. It is our intention not to discriminate, be judgmental, or have bias towards anyone. These are not simply published words, but are practices we strive and train for to do our best each and every day. We must all be respectful and put our commonalities first. Our priority is your good health. We are here to help you, and we want each and every one of our patrons to feel comfortable in our patient-centered medical home. It is this essence of equality that defines who we are. Please join us in this endeavor. And it is an endeavor because it's a continual quality improvement process that the entire medical staff needs to be cognizant of. You can never take this for granted. It is our safe harbor when people walk in. So this is the first thing people see when they come into our office. I'd like to offer it up as a best practice, but you can develop your own statement. But I think it's important when somebody walks in and sees this, I think they realize that regardless of what their race is, regardless of what their sexuality is, I think it gives a strong message that they're in a safer place, that they can be open and honest and not be in fear or in hiding. So you need to create a welcome clinical environment. Certainly this non-discrimination poster is one thing that you can do. But signage and office brochures are very important. Now, I'm not saying that every office needs to plaster itself with gay-friendly brochures and posters, but I would think every office should have something. One organization that I support very well in the Detroit community is PFLAG, Parents and Friends of Lesbians and Gays. And I have their brochures right in my waiting room, because you never know that it might be an aunt or an uncle or a mother or a father or a sister or brother that has an LGBTQ person in their family. And maybe this is one way of reaching out and communicating, or they see that and tell their brother or sister that's LGBTQ, hey, you know what, you should go to the Be Well Medical Center because it seems that they're a very competent, culturally competent place to go that you can feel comfortable with. Because not all people and minorities feel comfortable. And it's our job to make them feel that way. You might want to acknowledge relevant days of observance like Gay Pride Day. Again, if you're a LGBTQ organization, you could plaster it all over the place. I've seen many that have. But even at a quote unquote straight clinic, to have some sort of signage saying that you're accepting of this lifestyle, to have ethnic diverse posters, sorry about that, out for people to see also makes a very good statement for your clinic. So these are all things that are welcoming and give people comfort that they're getting out of that stormy sea and going to a safe harbor where they can talk about themselves and get the care they so needingly are rightful to and deserve. I think it's worthy to have a discussion with all our patients and clients about confidentiality. Who has access to their records, how test results remain confidential, your policy on sharing any information, and then certainly There are some instances where confidentiality is not possible, and I'm thinking there more with subpoenas and the legal system that could be mentioned as well. Perhaps you want to have a confidentiality statement and display or give that out as well. And make sure your staff are trained on that confidentiality, because patients may ask their staff, for the receptionist or the phlebotomist or the medical assistant, about confidentiality. Everybody needs to be on the same board. There is nothing worse than having an untrained, unfocused staff in your organization where you're giving mixed messaging out about anything, but especially something so sacred to an individual as confidentiality. Your forms are also important and make a statement about how you feel in your office. Use relationship instead of marital status. On your intake forms, add a transgender option. Show empathy, open-mindedness, and do not give judgment. Use the same language that the person is using during discussion. Let the patients take the lead. And if the patient has a language that you're not really sure what they're talking about, the patient will respect you if you ask them to clarify any terms that you're unfamiliar with. And above all, don't prejudge and infer heterosexuality, because the second you do that, if you have a person that's not out, that has low self-esteem because of their sexuality, and they've had to live in the closet for so long, if you infer heterosexuality, they will clam up. They will not talk to you. You don't want to make statements like, oh, you're a handsome guy, I bet you got a lot of girlfriends, or things like that. They're just not appropriate. Staff sensitivity and training is absolutely a must. My office, we have openly LGBTQ staff. We have some that are heterosexual staff, and we all make mistakes once in a while. What we're having a problem right now with is pronouns. Our electronic medical record makes us use the sex and the name that's listed on the insurance policy. Our EMR, at my insistence, we also have a spot to put in preferred names and preferred genders, but it's hidden. It's not clear light like their legal name is. So we make mistakes every now and then. We're getting better and better. It's a continual quality improvement process, but you really need to have staff meetings and regularly talk about your office standards of respect and train individuals to be sensitive to all lifestyles. Again, we want to be a safe harbor for all of our patients. We don't want to offend anybody. Nobody said this is easy. It's not like pushing the easy button and it gets done. It takes a commitment and continued quality staff training to be able to accomplish this and do it in a well way. And believe me, we're cognizant at my office of this, but we're not perfect. But we've set the strategy that we continue to get better and better. And I don't chastise or get mad at people for making mistakes. We take the opportunity when somebody makes a mistake as a learning opportunity so they don't do it again. So we're going to switch over now to sexual health. Sexual health is a must in discussing with your patients. And unfortunately, many offices sweep sexual health under the rug. I don't understand it, but people, providers, social workers, psychologists just don't want to talk about it. And it's a very, very important part in people's lives. If I can do nothing else today but give you one take-home point, that one take-home point would be to discuss sexual health with your patients. And we're going to talk a little bit about that in a minute. But I want to give one example about sexual health, and I'm going to bring it very home and talk about my family. My older sister got divorced about 6, 7 years ago. And she is now into the dating scene. She's in her mid-70s, but she's going out, and God bless her. I want her to go out because it's less phone calls that I have to have with her every day. It's, she's got others in her life. Do you think, and I did not put this in as a polling question, do you think that her internist or her gynecologist has ever talked to my sister about the fact that she's sexually active and dating? You better believe they have not. And that's not unusual. And so we need to get this topic of sexual health out into the open, because many people are living hidden lifestyles. Many people have gotten poor education off the streets, especially our adolescents. And where else can they go for good advice than to their doctor's office? I don't care if you do a terrible job of discussing sexual health. Any job is better than no job of discussing it. So when you're taking care of patients in the primary care approach, you need to have a comprehensive plan for dealing with sexuality, sexually transmitted infections, and HIV for all your patients. You cannot, it's impossible to think that you would know the sexual habits of every one of your patients that walk in if you don't ask the questions. You cannot prejudice yourself by prejudging. You can't prejudice yourself if you have a 400-pound individual and think that they are not sexually active. You cannot think if you have a paraplegic wheelchair themselves into your office that they're not sexually active. And let me just tell you, if you don't know, the autonomic nervous system is responsible for sexual activity, and spinal cord injuries, etc., have no influence on sexual desire and/or performance. So you can't choose. You need to ask the right questions in the right way and take a sexual history, and then you can guide yourself from there as far as what type of education the person needs and what type of sexually transmitted disease, including but not limited to HIV testing as well. Times for taking sexual histories, new patients is certainly a good time to do it. Yearly wellness visits are a good time to do it. And I think you have a moment of opportunity if somebody makes an appointment to see you because they're concerned or have symptoms of an STI. Once you've taken that sexual history, then you can take the comprehensive approach and decide what type of sexual education the person needs. Certainly, the use of condoms is one part of sexual education, but that's the 101 course. There's a lot more to it than just condoms. Knowing the sexual status of your patients as far as number of contacts they're having. Are they having multiple partners or just one partner? Are they using drugs? I mean, all these things are involved with sexual education. And then and only then, you can determine a medical action plan for how much STI testing that they need. If somebody is not sexually active, then they don't need sexually transmitted disease testing. If they're very sexually active, they may need STI testing on a monthly or every other month or every 3-month basis. You really, really have to determine and ask the questions. I had one elderly gentleman come in to me that wanted to go on PrEP. And I spoke to him, and it turns out he has not been sexually active for several years and doesn't plan to be. And I said, why do you want to go on PrEP for HIV prevention? You're not a high-risk individual. He said, because I read it in the papers and that it's the responsible thing for a gay man to do. And so my response to him was, if you change what you're doing sexually, you start having sex with people, come back to see me and I'll be happy to prescribe PrEP for you. But I don't want to prescribe medication for you if it's not necessary. I had another man come in his mid-60s as well, a heterosexual man, that his wife was an invalid. They have not been having sex for several years, but he would go out and see prostitutes. and he'd see them fairly regularly. And he was worried about this. He loved his wife, but he didn't want to bring anything home to the family or get an STD. He was a person I put on PrEP because he was high risk. Now, I was lucky on both of those occasions. Those patients came in and they had something specific they were asking me for. But if you don't ask the right questions and find out what people are doing, you're never going to know who needs what. Again, I'd like you to take good sexual histories. We're going to talk about it in the next slide or two. But even if you don't take a good sexual history, it can be a skill that can be improved upon with practice, but you've got to practice. All right, so we got another polling question here. Sexual health is A, the absence of disease, B, being out of the closet, C, emotional, social, and physical well-being, D, practicing safe sex, and E is monogamy. Please answer now. Is it working?
Sorry. I just saw one.
There we go, technology. We'll give it another minute or two. Well, I'm speaking to a very smart audience. Again, I'm preaching to the choir. The World Health Organization defines sexual health as sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, and the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. The American Sexual Health Association defines sexual health as sexual health is the ability to embrace and enjoy our sexuality throughout our lives. It is an important part of our physical and emotional health. Being sexually healthy means understanding that sexuality is a natural part of our life, recognizing and respecting the sexual rights that we all share, having access to sexual health information, education, and care. And it also includes making an effort to prevent unintended pregnancies, being able to experience sexual pleasure and satisfaction when intimacy is desired, and to be able to communicate about sexual health with others, including sexual partners and healthcare providers. How much training have you received to perform sexual histories? None, some but inadequate, and the third choice is being blacked out here, or extensive. If you can please quickly answer that. How much training have you received? All right, so everybody here is putting some. In my mind, some is, oh, here we got a couple more coming in. Okay. Well, I'm glad to see that, a third of the people have had extensive training. I think that's one of the changes that we've had in society since the 1980s. In medical school, I mean, we received none. So it's nice to see that about 2/3 of the people have had at least some training and taking sexual histories. So the first thing you need to do when conducting a sexual history is set the stage. That requires establishing trust and rapport. You don't have a best friend after meeting them for 5 minutes. Establishing trust and rapport takes days, weeks, months, many visits. So you need to act appropriately. You may not want to take a deep dive into somebody's sexual habits until there's a better rapport of trust and of trust. If you're able to comfortably take a sexual history initially when you don't have that rapport, trust, or relationship, then go for it. One of the things that's most important And remember I said, if you take a terrible sexual history, so what? You'll get better with time. But the one thing you absolutely have to do is be yourself. Don't try and be somebody that you're not. Don't fake it. Because if you fake it and you try and you're not yourself, your patients are going to sense that in a heartbeat, and they're going to clam up, and they are not going to trust you, and they are not going to talk about their sexuality. Many of them are very, very frail to do so. When you have trust with the patient and you start talking about their sexuality, many times I have found it difficult to shut them up. They go on and on and on. And I guess it's good that they vent. And I think then you know that you have a trusting relationship with them. When conducting a sexual history, there's the 5 P's of sexual health that you should discuss. The first one is their partners. Ask about the number of their partners and the gender of their partners and their risk factors of their partner. And drug use is really pretty important because people sometimes don't make right decisions when they're under the influence of recreational drugs. Multiple partners is extremely important. Monogamy has changed. I mean, monogamy used to be one person and that was you in a relationship. Now it's like serial monogamy. Well, yeah, doctor, I practice monogamy with this person one week and monogamy with another person the next week. So, you really need to be specific. You need to talk about their sexual practices, whether they're using condoms. When I talk about condom usage, universally, what I get is, do you use condoms? Well, sometimes or most of the time. And then my follow-up question is, well, if you're having multiple sex partners and you're meeting lots of people online through Grindr or Tinder, whatever it be, how do you choose when to use a condom, when not to? And that's when their jaw opens and they really can't answer that question. You want to ask about past history of STIs. HIV is a kissing cousin to all other sexually transmitted infections, and they're all kissing cousins with each other. It's not unusual that I get a new patient come in with what I call the trifecta. They turn out that they come in, they're positive for HIV, syphilis, and gonorrhea, all 3 at the same time. Sometimes one problem brings a patient into the office, and when you start doing a sexual history and testing, you find out they got more than they thought they had. And then a sexual history, if appropriate, should certainly talk about pregnancy plans. And if somebody is not interested in becoming pregnant, to talk about different types of contraception if they're sexually active. So this is really it in a nutshell about taking a sexual history. Doing it is the easy part. But thinking about doing it, that's the hard part. Some specific issues when you're taking a sexual history with your LGBTQ patients: explore the degree of how much they are out. Some people are out to friends, but not to family. Some people are not out at the workplace, but they're out to family. There's all different choices of that closet door opening and closing, and you should talk to a person as to what degree that they are out. Understand the LGBTQ patients are vulnerable to many social stresses, and that could lead to harmful and self-destructive behavior. It also leads to low self-esteem. That coming out process is a process that takes time. Not everybody beats to the same rhythm of coming out. Again, in the year 2021, I think it's a lot easier for people to come out, but even with that said, there are still a lot of people that have hidden lifestyles. In the 1980s, I was a clandestine doctor for bisexual married men. They would be married, have families, but have a hidden lifestyle of meeting men in bathhouses or restrooms or other areas. From my anecdotal experience, the number of bisexual married men that do that is much less than it was in the 1980s. Talk about safer sex techniques, discuss HIV, and discuss social media. in today's day and age, especially in the LGBTQ community, but certainly not restricted to that community, people are using social media for no strings attached sex, and very casual sex. Sometimes they don't even know the person's name. Well, let me tell you, people on social media lie. I see it for myself. There are patients and people that say they're HIV negative when they're HIV positive, and there's people that say they're on PrEP when they're really not, or when they're HIV positive. So part of the discussion needs to be risk against HIV and other STIs is a personal approach that must be layered. You need to choose it for yourself, what type of risk you're willing to take. But nobody should believe social media just because it's published on social media. People need to do their due diligence to find out if it's true or not. When you're taking a sexual history, you should evaluate patients to see if they have been a subject of violence. Has anybody ever hurt you, or currently or in the past? Have you ever experienced violence? Have you ever been sexually assaulted or raped? You don't get the answer that often, but so many times people are hiding baggage about previous sexual encounters that it affects them in their life. And as a physician, many times I cannot really help them in this endeavor, although I certainly can refer them to an emotional health care provider and let them go into deeper details about what has happened and to help them cope with it. Training for sexual histories in medical school is not that well. This is a survey of medical students, residents, and fellows designed to explore comfort, knowledge, and training in taking sexual histories for both all patients and the LGBTQ. If you look on the right column in the yellow, 20%, that's 1 out of 5 respondents in the survey, said they received no training whatsoever in managing or taking sexual histories for a lesbian or gay individual. 40% that said that they had some training. And if you look, only 8% said they had extensive training in dealing with this community. And when taking sexual histories on all patients, it's really not that much better. Pretty much answered it like you did. About 2/3 said they had some training, but a lot of people admitted that there really was not that much training. And only few had extensive training, a minority for sure. Same thing goes with the comfort level of taking sexual histories. I don't know why, but the older generation is much less comfortable in taking sexual histories than the newer generation. So newer generation out there, I'm counting on you to lead the way and be best practices with your peers and with older physicians when you're out in training to talk about taking sexual histories. And you can see here again, there's more uncomfortableness in taking sexual histories than there should be, whether it's a gay or straight population. And, we need to get better. When you're talking about STI rates, there always has been, and there continues to be, more cases of STIs in men having sex with men. That's indicated in the top graph with the blue line, as compared to sexually transmitted diseases between men having sex with women and women in general. It's a much higher percentage. And you should remember this, because if you're dealing with somebody in the higher risk group for STIs, you may want to spend more time with the sexual history and more time with education in talking about STIs. And if you look at the lower graph, irrespective of age group, less than 19 or over 40, men having sex with men lead the way in every age group for STIs as compared to the counterparts of men having sex with women or women in general. When you're screening for sexually transmitted diseases, if somebody comes in and they say, I want to get checked for STIs, you need to find out what orifices they're using and swab everyone that's being used. This slide that was done in San Francisco, albeit a few years ago, but still the data is the same. They found out that they would have missed 77% or 95% of chlamydia or gonorrhea if they did not swab rectal swabs instead of just getting a urethra swab or pharyngeal swab. So you get a sexual history, and this includes women because a lot of women are anal receptive as well. And a lot of cultures, whatever, really want that more than vaginal sex so they can be considered virgins before they get married. So you need to ask the question, if there's an orifice that they're using for sex, it needs to be swabbed. If you think, oh, if you just get a cervical or urethra culture, you're done, you're going to be missing 3/4 of the STIs. And believe me, I see this in my practice all the time. 85% of the time, rectal gonorrhea and chlamydia are asymptomatic. The lifetime risk for an African-American gay male to become HIV infected is A, 10%, B, 25%, C, 50%, D, 75%, or E, unknown. %. Again, I'm singing to the choir. So isn't it interesting that if you look at African Americans in the royal blue, it represents 13% of our population. Yet if you look at the pie graph on the right, equals 45% of the new HIV infections. And this has not changed. If you look at the Caucasian population, it represents 62% of the population, yet only 27% of the new HIV incidents. This has not changed. If anything, it's gotten a little bit worse. And I think we need to take this messaging to really do more education with the African American population, because I think many are not aware of the increased risks that they have. Lifetime risk of getting HIV in white women, 1 in 880, white men, 1 in 132, men having sex with men, 1 in 11. You can look at the Hispanic rates as well. I'm not going to read them out individually for lack of time. You can see the MSM is 1 out of every 2. These are real numbers, my friends. And we are doing a little better, but we're still in the United States at 40,000 plus new cases of HIV every year. I thought that COVID would slow down the rate of STIs and HIV. Well, anecdotally speaking from my practice, I'm treating as much STIs, as much syphilis as I ever have, perhaps more. And I'm seeing as many new cases of HIV being diagnosed, even though we're in the COVID pandemic. Self-perception of HIV risk is low, especially in adolescents. They have that thing, it could never happen to me, it could happen to everybody else. This was a study done in Philadelphia at an STD clinic. They had people fill out a questionnaire rating what their self-perception of their risk was. In that, men were 57%, women were 8%. Then they had the tester evaluation come in with the same questions, do a little bit more detail on the data, and they found out that the risk in men was 72%, and look at the whopping difference in women, up to 60% were at high risk. So self-perception is extremely less than what their actual risk is. HIV management, we've come a long way. It's a chronic manageable disease. I think I'd much rather have HIV than I would diabetes. There are single tablet regimens, 1 pill once a day. They're non-toxic. There's no adverse events, very few. The key when it comes to HIV management is people need to take their medication 1 pill every day or whatever they're taking as if their life depends upon it, because it does. If somebody gets diagnosed and goes on rapid initiation of therapy, then chances are they will never have anything HIV related that's going to kill them. But the hard part is taking it every day. People miss medicines for many reasons, whether it be blood pressure, cholesterol, diabetes. Some people just get tired of it and say, I'm going to skip today's dose. I don't want to take it today. An HIV-infected person on successful therapy for 6 months or longer cannot transmit the virus. True or false? Great. So, it's U equals U, undetected equals untransmittable. This is extremely important when it comes to HIV prevention. That's one of the reasons we do the test and treat strategy. The sooner we get somebody undetected, the sooner it is that they cannot transmit the virus to anybody. We've known this for a long time, but a lot of HIV physicians have been patternistic, and we've been scared to tell people that. But this has actually been proven with the Swiss statement, which is a null hypothesis, which is something like this. If somebody has been HIV infected for more than 6 months, have they spread the virus to anybody else? And out of hundreds of thousands of cases that's been reviewed, they have never found anybody that's been HIV treated where they're undetected, not using condoms, and they've spread the virus to somebody. So unless somebody breaks this null hypothesis, we now say it's a true statement. Treatment for persons living with HIV includes 1, only oral medicines, 2, only injectable medicines, and 3, both options of oral and injectable medicines. Please choose. I know I've got about 8 minutes left and I want to get through. While you're choosing, I'm going to answer, that's correct. There is a new medicine that's been approved recently called cabotegravir. It's an injection that people take once a month. I'm very confident that in a short period of time, that injection is going to be once every 2 months. And it's a real nice thing because a lot of patients, 1, can't take medicines every day, they simply forget, or 2, they don't like the daily reminder that they're HIV positive. Studies have shown that a lot of people prefer going in, getting an injection once a month, and not have to take pills every day. Also, we talked about people's doors opening and closing. A lot of people don't like to have medicine in their medicine cabinet for HIV because a guest may come in, and sometimes guests are snoopy and they look in medicine cabinets and they can see HIV medicine. So the injectable medication allows no medicines to be kept in the house that somebody may mistakenly find out that somebody's HIV positive. There are more than 1 million adults at risk for sexually acquired HIV in the United States. Out of that, only 20% are actually on PrEP, an HIV medication that prevents HIV. PrEP is not the only answer. You have to determine how much risk you're willing to take. But, for a lot of people that are sexually active with multiple partners, have inconsistent use of condoms, they, would benefit from using PrEP. The answer here, the risk for HIV includes all of the above: inconsistent condom use, past STIs, if somebody self-identifies as being high risk, if they have a partner of unknown status or multiple partners, all of those are increasing your risk for HIV. And how do you find this out? By taking a sexual history. When somebody comes in for an HIV test, there's a whole spectrum of what you need to do. It's no longer, oh, you're negative, go home. I mean, we did that in the 1990s. If somebody is coming in for an HIV test and they're negative, you need to determine what risks they're having. You need to educate them and possibly offer them PrEP if they're at significant risk. If they get tested and they're positive, you need to immediately get them into care, retained in care. And I strongly believe, as many other HIV specialists do, is a rapid initiation of therapy, because that gets them attached to a provider quickly. It prevents the community where U equals U. I'm going to skip this question because I know I got a smart audience. Transgender health, very, very important. I'm seeing more transgender individuals come into my office, young people coming in with their moms and dads. Let me just tell you, from my experiences, patients, when they come out and they're transitioning, all they want is hormones, 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 hormones. And hormone replacement is part of transitioning, but their mental health and how they feel about themselves, and how I like to explain it to my transgender individuals, is what's in your heart. You can be a normal transgender individual and not be on hormones at all. Yet we need to be careful, especially providers. It's not just about hormones, because they're going to want more and more and more. Historically, that's what this population wants. Every transgender individual needs mental health and needs to be in support groups within their own community that they can discuss issues. Being transgender is much more than just going on hormones. There's a lot more to it. I put in some definitions here. This is the next before the last slide. People have a biologic sex. That's what their chromosomes are, XX, XY. It's what genitalia they have. Intersex is where there's some variability in that, and it may not be clear whether they're one sex or another. Gender identity is how somebody thinks about themselves, if they think about themselves as being a woman or being a man, or somewhere in between is gender queer. Gender expression is how they demonstrate their gender, how they dress based on traditional gender roles, the way they act, behave, or interact with others. It can be on the scale from feminine to masculine. And then sexual orientation is who somebody is physically or spiritually attracted to, whether they're straight or gay or bisexual. A lot of people don't really know these definitions, but they're important. So our last slide now is I found this presentation to be, and then you can fill in the blank with whatever word that you want to put in. This is my last slide, and they're going to cut me off in a minute or two. I hope that you found this presentation beneficial. My goal is to give you at least one thing that you can do better, one thing that you can think about. This does not mean that you should do this only with your patients. You might want to have discussions on human sexuality with your friends, with your families, your nieces, your nephews. I found grandmas and grandpas that talk to their grandkids about sexuality. Isn't that awesome? You know, we're all dedicated people. I feel your passion, and you need to keep that passion going, not only to your patients, but to everybody else. You know what? This is my life. HIV and being an LGBTQ physician has molded me into making me the person that I am. I'm very, very proud of that. And I feel your passion as well. And you guys, need to do the same thing. God bless you all. Keep it up. Maybe next year I can come back to your beautiful city of Traverse City, and we could talk in person. Thank you very much. And thank you for that great feedback. You're making me smile.
Thank you, Dr. Benson. Our next session will begin at 11:15. We're having a little technical difficulties, so bear with us if it's a few minutes late. At that time, at 11:15, click on Join Session in the Program tab after leaving this session, or click on Join Session in the Session tab to the right of this video stream. Thank you, Dr. Benson.
You're welcome.